depends on whether they get COVID and their intrinsic vulnerability to it. So, and we've done this before. We have prioritized other occupations like healthcare workers. There are many reasons to prioritize teachers. Exposure and risk is obviously one of them, but the other is that there is a sort of social contract with teachers who are expected to sort of teach in this environment and take these risks. And of course, from a very selfish perspective as well, them being absent and becoming ill means entire bubbles need to isolate. They're not available to teach. So even if you're looking at less disruption of education, that's something worth considering. But also from a perspective of mixing and transmission, there's a lot of evidence now that we don't just need to hit vaccines towards vulnerable individuals, but also need to do it in groups where there is a lot of mixing as well, to really bring down the overall risk of everybody getting disease, including the most vulnerable. So I do think that we need to update our vaccine policy. And when people say we can't prioritize certain occupations, we've already done that. So I don't see why we can't.
I'll make a quick comment.
Certainly.
So, yeah, just going back to the point about the Scottish Government strategy in April 2020 about drawing on the best evidence, and the commitment that the government had that it would draw on the best evidence. It's been very difficult at times to work out what evidence it's been drawing on. I heard Dipti having the various exchanges with John Swinney, and Dipti has clearly got a great deal of evidence about some of the issues that not only affect school teachers, but affect education staff as well. And in some of the documents that the Scottish Government published, its own documents were flagging up risks for various school teacher groups that were above what you would expect. I think we do have evidence. The World Health Organization actually put out scenarios about how you should treat vaccine priority. And in there was the whole point about exposures of workers and exposures of people in the community. And as Dipti said, this has been around a long time. So in May and June, the French, the Germans, and the US were saying we should be prioritizing various groups. Centre for Disease Control said that, in fact, teachers should be prioritized in the States because of the exposure, because of the fact that schools wouldn't function if teachers and other staff and children got COVID. So where is the best evidence then that the Scottish Government was acting on there? It doesn't seem to have been looking as widely and as deeply as it should. And I think that's something that runs through, the other sectors as well.
Thanks for that, Dr. Watson. Can I just say that another one of these questions actually ties both of those together. Group 4 are asking, why are so many public health scientists and advisors basing their advice on the unreliable evidence rather than the evidence Deepti provided? Because not doing that is abandoning the precautionary principle. So I think that kind of ties in both what you've both just said there. Yeah, Dr. Whitford.
Well, I think one of the issues has been that the Scottish Government normally follows the advice of the Joint Committee on Vaccination and Immunisation, the JCVI. I think starting out, we didn't have evidence as to whether these vaccines would prevent transmission or only protect the person getting them. So initially the deaths were absolutely among older people, and therefore it was delivering the protection to them as quickly as possible. And obviously we've seen the impact of that in the fall in care home deaths and hospitalizations. But there was an expectation that as evidence that the vaccines did seem to prevent you transmitting the virus, that therefore things like exposure would come into this second phase from the JCVI, as well as, so that would apply to people working in supermarkets, people in public transport, and not just public sector workers like police, fire, and teachers. Now, the problem is for those who work for private companies like a supermarket, actually identifying them is much harder. Public sector workers could be more easily identified in that we employ them, so we're aware of them. But I think the bottom line issue is that along with all 4 governments in the UK, the decision was, as previously, to stick to the JCVI advice. And while it was expected that the second phase, i.e. those below 50, there would be more account taken of exposure, that's not what the JCVI have done. They have still come back and recommended that we should be sticking to age cohorts.
Thanks very much for that, Dr. Whitford. I have one further question here. I'm just trying to fit them all in. From Group 2, Glasgow Social Work. They would like to find out if there's any way of getting standards on ventilation that are actually enforceable. Otherwise, it's very difficult. The TUC and the hazards guidance considered best practice versus the CIBSE standards. Is there any way that we could have a standard for this? Because I do know that this isn't included in risk assessments in workplaces and things like that. Would anybody like to answer that?
Well, I think we've heard that there are these other good sources of information. I think there'd be a difficulty having a generic standard because it would depend on the circumstances. Again, I think we've heard statements from the Scottish Government, for instance, that ventilation standards are being checked in schools on a regular basis, and that there is some information there. But I don't know. The EIS and UCU and other people here may have seen this information, but it's not been made available that I'm aware or readily available in the public domain. So working out exactly what the standards might be in a particular school, for instance, or in a particular workplace could be quite complicated. But other countries have done it. And obviously the Scottish Government does not control what happens in workplaces, although it may work with public health staff to try and develop the guidance. Nevertheless, it's not fully in control of that. So I think what we'd be looking for is the Health and Safety Executive taking a much bigger lead, more information coming out from the Scottish Government departments, and operating a sort of best practice that, for instance, the Hazards Campaign, Scottish Hazards, and others have advocated. What is rather surprising is that bodies like the British Occupational Hygiene Society have been recommending various measures on ventilation and protective equipment that, for instance, at the moment, the Scottish Government doesn't seem to be following. So, lots of good things that it's done, but it's still inexplicable sometimes to work out why it isn't acting on the evidence that's there.
Alan, you want to come in on that?
Yes, thank you. I just want to come back on a couple of things that have been said by Philippa, Andrew and Deepti. The EIS has been campaigning on vaccinations, masks, ventilation. And we did ask to have teachers prioritized, not ahead of the first group, obviously. It was going to be after that. Now, Philippa, I think the JCVI have made that decision for logistical ease reasons. They're only wanting to roll it out via age thereafter because it's easier. The government could have said, well, actually, no, we're going to prioritize teachers, shop workers, and other professions or workers who are exposed to it. So, I think it's a shame that they've, in a way, used the JCVI as a kind of shield. They could have made that decision. I think now we've accepted that that part of the campaign is dead in the water. We're not going to win that one now, and so it's really about the higher quality masks, the FFP2 masks as being more safe that we're asking for, and much better ventilation measures. And for all the reasons that Deepti mentioned, not just selfishly because it's going to protect us and the kids, but because it's going to protect education. You're going to stop outbreaks, and then, for the very thing that you're protecting and prioritizing, why not just have those easy wins? You know, give out those masks and go in and improve the ventilation.
That's great. Thanks for that, Alan. Ian, you wanted to come in as well?
Thanks, Mandy. Yeah, I'm grateful to Dipty for showing those slides, because it's kind of verified the concerns that I've had about the school establishment for a long time now. I think in Edinburgh, the senior management team were taking the point of view that the Westminster guidance was what they were going to stick to, and that was it, because there was very little guidance at the time coming through the Scottish Parliament. And I've recently been in touch with Andy in regards to my kind of campaign at the moment to try and get the realistic figures of positive cases in Edinburgh. And one of the concerns that I had was that there was constant guidance coming out from Westminster that children were not particularly susceptible to the virus, although they were carriers. But the fact of the matter is that in Edinburgh, because we've continually requested these figures, I mean, the latest figures that I've got for schools, I just looked them up when we were in the breakaway rooms, are totaling 762 cases. Now, I know for a fact that when we went into lockdown from March last year, they weren't actually tallying the positive cases between March, and we actually stopped calculating early years positive cases in August. So, for instance, if I could very quickly run through it, in primary schools, there's 428 cases, 283 pupils, and 145 staff. Secondary schools was 292 cases, 244 pupils, and 48 staff. And special schools was 42 cases, 6 pupils, and 36 staff. And that's affected 121 schools in Edinburgh. So that's a total of 762. Now, the official figures that I'm getting from our corporate health and safety that have been logged on our SHE portal for positive cases in all departments is actually 560. So there is a massive discrepancy there. We've already done retrospective checks on safer and stronger communities, community and families. I've asked them for the police directorate, where that's the vast majority of manual workers working. The other problem that we had was in relation to staff from schools and particularly care that come from our BAME community, because again, the information that was coming back from the government was all based in England and Wales predominantly. And I actually had to write to Sarah Boyack, the MSP, and ask her to raise it in the Communities Committee at the Scottish Parliament. Now, as a result of that, we started getting a BAME working group at the Scottish Parliament, but there is still very little information coming back from that.
Thanks for that, Ian. Deepti, you wanted to come back on that?
Yeah, I mean, I just want to respond to an earlier question, I think that was asked about why is it that scientific advisory groups are sometimes sort of presenting or looking at different evidence than what we've sort of presented here today. And I think that's a really important question. I mean, I've become very concerned over time that there's certain narratives that are evidence-based that are being suppressed. I did an interview on BBC Scotland a while ago where I criticized the school opening strategy in Scotland, suggesting there weren't enough mitigations in place. And soon after that, I was contacted privately by very senior members of the scientific advisory group in Scotland, suggesting that I was undermining public messaging and doing harm. And there was a lot of pressure to sort of stop discussing this publicly. And this is not a one-time issue. I know several of my colleagues who've done something similar have had sort of threats to their employment with complaints against employers, calls for retraction of papers. So there's a broader sort of picture here, not just again around school transmission, but I feel like a lot of evidence-based narratives that are not in line with policy are being suppressed by actively targeting particular scientists who are sort of just putting information out there. And I think this is something that needs to be seriously looked at. And I think, I mean, I don't know the reasons for this. I think, of course, many scientists are obviously invested in a narrative that they've sort of backed quite early on, and it's quite difficult to change it. I'm not suggesting that there's anything nefarious happening, but I'm just saying that it's quite difficult to actually even discuss the evidence right now without fear of retaliation in some way. And that's something that needs attention urgently.
Thanks for that, Deepti. Thank you very much. I can fit another question in. This might be for you again, Deepti. Mask inertia. Are people still wearing cloth masks? Would it be better to encourage FFP3 N95 mask usage? Does this make a difference? And how much or little emphasis should be placed on these smaller personal measures?
So yeah, the grade of mask certainly makes a difference. I mean, we are very behind in the UK in this conversation because countries like France, Germany are already moving to FFP2 masks on transport, including in schools, and we are still debating whether we need to use masks or not. So cloth masks are certainly less effective. So I think the effectiveness is about 50 to 60% compared to FFP2 and FFP3 masks, which are obviously more than 90% effective. But of course, it's not just the grade of mask, it's also how masks are used and fit, which I think we don't probably talk about enough and have enough of a conversation about, because you can have an amazing grade mask that doesn't fit and isn't protective very much. So yeah, we definitely need to start having those conversations. I don't know how to even enter that space, given there is so much backlash against just using masks, including, for example, in the school environments where it's been well tolerated and used in millions of children across the world. But I would really like to be able to move to, discussing grade of masks, although it sort of seems premature because we've not even left the debate about mask space yet.
Could I just comment on that? Sorry.
Yes, certainly, Dr. Watson.
Yeah, I think this does tie in with the whole issue of evidence and how information is accepted, and how very often the Scottish Government or its advisors seem to be following the lead of what's going on in the UK. So there have been numerous questions about the suitability and the quality of masks. And recently, the British Medical Association, the Royal College of Nurses and so on, flagged that they thought that within hospitals generally, the level of mask wasn't adequate, that they were looking at FFP3s. When this happened then, the British Occupational Hygiene Society specifically wrote to the Deputy First Minister and said that they supported that position because they were the specialists doing the research on masks and ventilation. And the response from the Scottish Government was basically, we follow the lead of the various other bodies. Now, recently, the Royal College of Nurses published a report showing the inadequacy of the reviews that were done on ventilation and masks. They didn't meet the appropriate standard, quality-wise, and they were ignoring the evidence. So I think there is a big issue, and it doesn't really show that there is best mitigation going on. I think the phrase that the First Minister has been using is reasonable mitigation. And I think in a pandemic, then you want the best masks, you want the best ventilation possible. Philippa, I think, wants to comment.
Yes, Dr. Whitford.
Yeah, thanks very much. I mean, I think similar to the issue around the JCVI decisions, I mean, the devolved governments have always followed the JCVI advice on vaccination. And there was a decision very early on that Public Health England would draw up the PPE guidance and all 4 governments would follow it. And there was a lot of discussion at the time about various specialties feeling they didn't really have the PPE that they should have. And I think this is even more important in view of the B117 variant, which is now dominant across the UK, being just so much more infectious. So I wrote a written question. I spoke to a contact in Public Health England saying, are you not going to revise your PPE now when you consider that the 3rd wave was very much driven by this extra infectiousness? And the response I got both from government and a PHE contact was, no, we're not. And so I think there is an issue of the devolved governments accepting, including back in March, when we hear the First Minister wanted to lock down earlier, but this was the sage advice, this is what the UK is doing, this is what the CMOs have agreed. But in actual fact, I've met with BMA reps, with RCN reps about the issue of PPE, and it's clear that there are trusts in England who are just changing. And the danger is, you know, all four governments, all three devolved governments think, yeah, okay, we've agreed, this is what we're doing, but you're not aware that actually not everyone is sticking to that guidance. And I do think there is a need to look at the PPE in hospitals. I'm not sure that I would be convinced, if people are socially distancing in normal society, that we would be expecting everyone to be wearing FFP3 masks. That certainly would help generate a shortage within the NHS. But people in intensive care, people in COVID positive wards or in A&E departments, I think we should be looking at the PPE that our staff are wearing, because this 117 variant is a different beast from what we were dealing with for most of 2020.
Thank you very much for that, Dr. Whitford. I have one last quick question. This one is, how do we build a zero COVID strategy from below, one where communities have agency and control? Would anyone like to come back on that?
Well, I think that there are sort of two aspects here. One is, you know, communities taking charge, because communities can take action towards zero COVID now, even if the government isn't being supportive of that. There are still actions communities and community members can take right now. But I think the other part is that, you know, the more you can localize responses to the community and to work with the community instead of delivering responses to a community, the more that the community will have agency, and then the more it will be a collaborative effort, which will not only make it more effective locally, but also really help to build and develop that trust with the community that is so essential if we're going to, say, change mask recommendations or really evolve the advice over time. We need to have that trust and that relationship with the community.
Thank you very much for that, Dr. Rossman. Cathy, you wanted to come in?
Yes, thank you very much. I'm Cathy Jenkins from Scottish Hazards, and I will be speaking later, so I'll speak very quickly. But I just think when we're talking about bottom-up action and community action, we really need to think about the workplace and to identify the amazing work, I think, that has gone on by unions. And I know we'll hear from some later, but that's very much bottom up, and it's been one of the most important things in terms of trying to address what's happening.
Thanks for that, Cathy. We do have a lot more questions. We will try and get some answers, and we will get those posted back to you.